Dr. Mazhar Amirali. I'm a physician and a nephrologist at Africa Health Network. I'm the Country Medical Director for Tanzania, but also Deputy to Dr. Lloyd, the Chief Medical Officer. All right, so today we are going to be having our Fireside Chat number 165. And Prof. Biruete is going to be taking us through the kidney and gut health case-based insights. But before she starts, I'd just like to give a brief introduction. Dr. Biruete is an assistant professor and a registered dietitian in the Department of Nutrition Science at Purdue University and an adjunct assistant professor in the Division of Nephrology at Indiana University School of Medicine. Her broad clinical interests in nutrition in the kidney diseases. Dr. Biruete's research aims to study the effects of nutritional and pharmacological therapies for chronic kidney disease on the gastrointestinal tract and gut microbiome. Additionally, Dr. Biruete is interested in improving the outcomes of Hispanic, Latino community living with chronic kidney disease, primarily through language and culturally concordant lifestyle interventions. Dr. Biruete is going to be, as I mentioned earlier, be taking us through the kidney and gut health case-based insights. Prof, the floor is yours. Thank you.
Thank you so much for that introduction. I'm going to share my slides now. Again, thank you so much. It is a true honor to be here speaking to you about a topic that I really like, that I hope that it's helpful for you all. There is a lot of development in this topic, so this is a really emerging topic. And these are my disclosures and conflicts of interest. But today, in the next 30 to 40 minutes, I hope to answer a few questions. One is, what is the effect of chronic kidney disease on the gastrointestinal tract? The second one is, what is the impact of chronic kidney disease in this accessory organ or virtual organ, which is the gut microbiome? And three, what can we do with nutrition to mitigate some of these gastrointestinal disturbances that occur with chronic kidney disease? So since this is a kidney-centric group, I don't think I need to tell you that the kidneys are probably one of the most amazing organs in the body. We don't say this lightly because the kidneys are the master regulators of homeostasis, and they perform several functions. I include 6 functions here. Some of my research is related to mineral and bone disorders, so that's why I have top and center here with mineral metabolism, because the 1-alpha hydroxylase is expressed primarily in the kidneys. And with this, we have the second hydroxylation and activation of vitamin D. The kidneys also control acid-base balance, one of the most widely known functions as metabolic waste excretion, electrolyte balance, blood pressure control, and the production of some hormones, including erythropoietin. Unfortunately, we have several things that will impact kidney function. The 2 most widely known and prevalent are diabetes and uncontrolled hypertension, but we also have some other things that will impact a decline in kidney function, including obesity, smoking, a natural decline of kidney function with age, and also more recently, the social determinants of health that have been highlighted, including access to education, access to housing, access to healthy foods. So since with kidney disease, kidney function is impacted, there's going to be several problems that will be developed. So as I mentioned, mineral metabolism is one of my areas of research. So there's going to be the development of chronic kidney disease, mineral and bone disorder, metabolic acidosis, the accumulation of metabolic waste products, dyskinemia, and problems with sodium as well, hypertension and anemia, as well as a variety of other things. And since the kidneys are the master regulators of homeostasis, virtually every single organ in the body, particularly in the advanced stages of kidney disease, it's going to be impacted, including the gastrointestinal tract and the gut microbiome, the cardiovascular system. You know that the primary cause of mortality in our patients is cardiovascular disease, problems with brain health, problems with musculoskeletal health, the immune system, which was very relevant, particularly in the COVID-19 pandemic, and changes in the reproductive system. So virtually everything is going to be impacted. So I'm going to center for this talk on the gastrointestinal tract. And I know that there may be some nutrition people and some dietitians here, but you may be aware and you may be seeing through social media that gut health is everywhere. Take a supplement for gut health, change your diet for gut health. I'll give you this for gut health. And really there's a strong interest, but I think right now a lot is hype, and we're slowly working on the data, particularly in chronic kidney disease. So there are several functions that the gastrointestinal tract is going to perform. As a nutrition scientist and a dietitian, I tend to focus on the digestion and absorption of nutrients, which is probably one of the most widely known functions of the gastrointestinal tract, but also functions as a barrier to the outside world. So for example, here's a representation of the intestinal barrier, just like intestinal cells, enterocytes, which are going to be in direct contact with the outside world, protected primarily by a mucus layer, which is going to stop that direct contact with the enterocytes. These enterocytes are going to be lined together through tight junction proteins that can also limit the translocation of things that we want, but also things that we don't want. There's going to be production of several enteric hormones that are going to be very important. One that is very relevant right now for the nephrology world and for like everything basically is, for example, GLP-1, but there's also some other enteric hormones. There's going to be this function of excretion through fecal output. The immune response is also going to be important in the gastrointestinal tract, and this makes sense since about 70% of our immune system resides within the gastrointestinal tract, and also its associated microbiome, which I will mention a little bit more detail in the next few slides. But this is considered a virtual endocrine organ that produces several metabolites that can be beneficial, but some others that can also impact different types of cells, and also helps us with immune system regulation. But what is the gut microbiome and the gut microbiota? These terms are oftentimes used interchangeably, but they don't mean exactly the same. So the gut microbiota is this diverse community of microorganisms. The ones that have been studied the most and the ones that our research focuses on is bacteria, but there's also some other microorganisms, including archaea, parasite, viruses, fungi, etc. The difference between microbiota and microbiome is that microbiota is really just the community of microorganisms, so who is there, whereas a microbiome is those microorganisms and their genomes and their metabolites. So it's really telling us what the function of those microbes are. It's really important because it's been associated and now causally linked to several nutritional pathways, metabolic pathways, and also linked to specific pathologies, including chronic kidney disease. And it also helps with the maturation and stimulation of the immune system. As I mentioned, about 70% of our immune cells reside within the gastrointestinal tract. And as I mentioned, it is considered a virtual endocrine organ. Virtual because they're microorganisms and we cannot see it. And endocrine because there's several metabolites that can be absorbed, travels through circulation, and have impact in other distal tissues and organs. On the right, I have this figure, which kind of exemplifies what are the factors that are going to impact the composition and the function of the microbiome. So in this one, simple nutrients, as we move through the length of the gastrointestinal tract, so from stomach to small intestine to large intestine, the amount of simple nutrients is going to be decreasing because the small intestine is going to be doing its work, hopefully, by digesting and absorbing those nutrients. So there's going to be very limited nutrients in the distal part of the large intestine. The pH also is going to be changing. The stomach is not shown here, but is going to be going from about 2 to 3, a pH of 2 to 3 to about a pH of 7 to 8 at the end of the GI tract. And also the quantity of oxygen is going to be different. There's going to be more oxygen in the proximal parts of the intestine, and this is going to be gradually decreasing. Also, the bacterial load at the same time is going to be changing. So there's going to be a lower bacterial load in the proximal gastrointestinal tract, and this is going to be increasing along the length of the tract, having the largest density in the large intestine. As you can see here, there's also going to be different types of microbes, and these are because they're going to be adapting to the ecosystem that is within this niche. And if we take a cross-sectional area of this, in this case, the large intestine, we're going to see that there's going to be a microbiome associated with the lumen of the GI tract. This is what we tend to study in humans because the way that we study it is through fecal samples. But also there's going to be a microbiome associated with the outer mucous membrane and the inner mucous membrane. So in chronic kidney disease, there's going to be a lot of things that are going to be impacting the gastrointestinal tract. The first insult, and probably the most important insult, is going to be the uremic milieu because it's going to be in direct contact with our intestinal lining. Also, as a dietitian and probably nephrologist in allied healthcare, you know that the medical nutrition therapy for patients with chronic kidney disease is going to be one of the most restrictive, hard to prescribe, and also hard to follow. And because of these restrictions, our patients tend to consume lower amounts of key nutrients for gastrointestinal health, including dietary fiber. Also, unfortunately, there's going to be polypharmacy and a variety of prescriptions for our patients, particularly with those with advanced stages of kidney disease. And it's not only obviously for the kidney disease itself, but all of the complications that are derived from kidney disease, including cardiovascular disease, the management of mineral metabolism, and the management of musculoskeletal health, etc. So you know, but the median pill intake in patients undergoing hemodialysis, at least in the United States, is about 19 pills a day. So you can imagine that some of these medications may have impacts on the gastrointestinal tract. When you look into the adverse effects, most of them are nausea, diarrhea, constipation. And also, unfortunately, sedentarism is an important problem with our population, and this can also impact GI function. So because of this, there's going to be a lot of changes along the gastrointestinal tract. So impaired intestinal barrier function, which is really important because this is going to increase the translocation of things that we do not want, including, for example, microorganisms and the components of microorganisms that will activate our immune system, increasing the production of pro-inflammatory cytokines. There's also going to be altered GI motility, particularly GI side effects, including constipation, which is probably the most common one in our patients with advanced stages of kidney disease, but also dyspepsia and diarrhea. There's going to be changes in the microbiome that could be because of the kidney disease, but also the gastrointestinal and the gastrointestinal microbiome impacting the development and progression of kidney disease. In general, this terms of dysbiosis in kidney disease is because of these imbalance, particularly with the production of key metabolites through the microbiome, having a lower production of the beneficial metabolites, which are short-chain fatty acids, and a higher production of the metabolites that we really don't want, that are now considered also uremic toxins, which are oftentimes derived from the metabolism of amino acids, including tryptophan and tyrosine and phenylalanine. And also, unfortunately, since we are talking about the GI tract, and I mentioned that, in my opinion, one of the most important functions of the GI tract is to digest and absorb nutrients, there's going to be impairment in the digestion and absorption of these nutrients. So all of these things are going to be probably present in our patients with kidney disease. So now let's go through all of those 4 major problems in the gastrointestinal tract. So the first one, the intestinal barrier in kidney disease, which is impaired. As I mentioned, probably the biggest insult is the uremic milieu. It was thought that urea was probably but one of the most important ones driving these changes in the gastrointestinal tract, because there were a lot of in vitro studies that cultured intestinal cells with different levels of urea that showed that the intestinal barrier was impaired. So a lot of these tight junction proteins, the expression of those was diminished. But now we know that there's other things that could also impact, including those key metabolites derived from the microbiome. In patients with hemodialysis, if we're thinking about intermittent hemodialysis, they may have episodes of intradialytic hypotension that can also impact the gastrointestinal tract, increasing intestinal permeability. As I mentioned, constipation is probably the most common gastrointestinal side effect, and also these effects could be driven by these gut-derived uremic toxins, and these can increase the translocation of microbes, the components of the microbiome. And as you remember, I showed a picture of a regular intestinal barrier function, but in patients with kidney disease, there's several things that will be impacted. I mentioned the mucous membrane, that is a really important thing because it limits the direct contact with our enterocytes. However, with kidney disease, this mucous membrane may be diminished, increasing the translocation. Also, these tight junction proteins, their expression may be lower in kidney disease. And as I mentioned, also the dysregulation of the immune system. In this case, we can think about the translocation of bacteria, lipopolysaccharide, increasing endotoxemia, activating the immune system, increasing the production of pro-inflammatory cytokines. And also, depending on the damage of the intestinal lining, there may be impacts in the transcellular, so through the cells, all of these transported, mediated nutrient transport in general, but also paracellular, which is between cells. And in this case, we're still in the process of researching. But for example, in our case, we're researching phosphorus. And this intestinal barrier dysfunction may increase the paracellular absorption of phosphorus, but again, it's still under development. Now, going to gastrointestinal motility, I really like this animal study. It is an animal that compared mice with normal kidney function compared to those that receive adenine in order to give kidney disease. So adenine is a toxin for the tubules, and that's the reason why these animals develop CKD. So in this first panel, what they assessed was gastrointestinal transit time, and they showed that those with CKD had a longer transit time. They also inserted a bead to see the expulsion time for that bead, and they showed that that was also increased. And they also checked for the number of fecal pellets, and they showed less fecal pellets, suggesting that there's more constipation, longer transit times, which is very relevant for a lot of things, but also particularly for the gut microbiome. In the middle panel, they did a mechanogram just to measure spontaneous motility of the distal colon. In panel A, you can see that there's a lot of variability and not a lot of spontaneous motility. But in animals with kidney disease, though, that spontaneous motility was virtually zero, which was really surprising. And then on the panel on the right, they also did several assessments. In this case, it was ex vivo exposure to either plasma from patients with normal kidney function or plasma from patients with hemodialysis. And they showed that there was a longer or lower normalized force in those that were exposed to the hemodialysis plasma. And as I mentioned, the thought process in the past was that urea was the single most important insult to the gastrointestinal tract, but actually in this research, they showed that some of the gut-derived uremic toxins, including picrosyl sulfate, derived from the microbial fermentation of tyrosine and phenylalanine, and also indoxyl sulfate, which is derived from the fermentation of tryptophan, were more impactful than just the incubation with urea. So I mentioned that there may be also problems with the digestion and absorption of nutrients. There's been a lot of preclinical data that has suggested that there is impairment both at the macro and micronutrient assimilation of those nutrients, including for carbohydrates, limited data, protein, a little bit more data, and fat, a little bit less data. There's also experimental data for the impairment of the absorption of some vitamins, particularly water-soluble vitamins, and also experimental data for the impairment of some minerals. So as I mentioned, my research is mostly focused on phosphorus, but there's some evidence that there is impairment on the absorption of some of the important minerals. In this case, I want to present data on a study that was published now more than 20 years ago from Dr. Peter Evenpool's group, in which they wanted to see if protein assimilation was different in patients with normal kidney function compared to those that had moderate kidney disease and more advanced kidney disease. In this one, they infused radio-labeled amino acid, and they showed that there was less appearance of that amino acid in patients with kidney function less than, I believe, less than 30. In this panel, they also measure urinary concentrations of this p-cresol, which is again derived from the fermentation of tyrosine and phenylalanine. And they showed that those with this is kidney function more than 60, kidney function between glomerular filtration rate, between 30 and 59. And this group is below 30, and they showed that those in the group B and the group C had a higher concentration in the urine of this metabolite. And that suggests that because there's more protein fermentation, there's less absorption in the small intestine, leading to that protein reaching the large intestine and come in contact with those microorganisms that can ferment that protein. At the same time, they also normalized it to the concentrations of creatinine, and they showed that urinary urea, and they showed that those that had moderate and advanced kidney diseases had more appearance of that protein fermentation, suggesting that the protein assimilation or the digestion and absorption of protein in patients with kidney disease is impaired. Now, going to the gut microbiome, as I mentioned, there's that question and debate. What's the chicken and the egg? Is it the kidney disease impacting the gastrointestinal microbiome, or the microbiome impacting the development of kidney disease? And right now, the results seem to be mixed. It seems to be a bidirectional relationship between these. And this is a systematic review of human studies of kidney disease that shows like what is the impact on the composition of the gut microbiota. This was done by Dr. Kelly Lambert's group, and they showed that in patients with kidney disease, they had a reduced abundance of those microbes that have been traditionally thought to be beneficial, particularly for the production of short-chain fatty acids, including, for example, Faecalibacterium prasense, which is a butyrate producer. However, in those with kidney disease, there's a greater relative abundance of those microbes that may have the potential of producing more gut-derived uremic toxins, including Proteobacteria, Staphylococcus, Phallophila, etc. In terms of the composition, it really depends on what the comparator is. If you compare a non-related group with normal kidney function compared to people with either moderate or advanced kidney diseases, there's a clear separation of the gut microbiome composition, showing that the microbiomes are different in those that have normal kidney functions compared to those that have kidney disease. However, when you compare people that are directly associated with those patients with kidney disease, for example, those living in the same household, the composition is not that different. It's really just the metabolites that those microbes can produce, which is really interesting. And that, again, is something that research needs to look more into. And I keep mentioning these gut-derived uremic toxins, but these are the ones that have been measured continuously in patients with kidney disease, not by chance, but these are the ones that, one, are derived from the microbiome, and two, are accumulated in patients with kidney disease. That could be an effect of production or a reduced elimination because kidney function is limited. So the example of tryptophan, it goes to indole through the microbial metabolism through an enzyme called tryptophanase. That indole is then absorbed, is oxidized and sulfated in the liver, producing indoxyl sulfate, and that's what usually is measured. Tyrosine and phenylalanine can also undergo a series of enzymatic steps from the microbes, producing p-cresol and phenol. These are then absorbed, sulfated, and oxidized in the liver, producing p-cresol sulfate and phenyl sulfate. And these are the ones that are measured in blood. And also some not directly amino acids, but of nutrients that can be found in animal-based products primarily, like choline and carnitine, can undergo microbial metabolism, either cleaving the TMA or trimethylamine moiety of that compound, or directly oxidizing to TMAO or trimethylamine N oxide. This, if the TMA is not oxidized in the liver by the microbes, it can be absorbed and then oxidized to TMAO, and that is the thing that we measure in blood. These indoxyl sulfate, p-cresol sulfate, and phenyl sulfate are protein-bound uremic toxins, so that's why when kidney function declines, they tend to accumulate more because they cannot be excreted. TMAO, it also accumulates, but this is not protein-bound. I'm switching a little bit here, but it's still related. Not surprisingly, because of all of these problems, impaired intestinal barrier function, impaired digestion and absorption of nutrients, impaired gastrointestinal microbiome, there is a high prevalence of gastrointestinal symptoms in patients with advanced kidney disease. This is a systematic review by a group in Australia, and they showed that variability. I mean, depending on the metric that you see or that you study, the symptoms, for example, constipation can go from less than 10% to all 75, 80%. Diarrhea is a little bit less variable, but you can see that there's a lot of variability. When they focus on those studies that use the gastrointestinal symptom rating scale, or the GSRS, they showed that the prevalence is still high. It can go all the way for constipation to 70%, diarrhea about 40%, indigestion about 70%, abdominal pain about 70%. So as you can see, the prevalence is pretty high. So again, as a dietitian, I like to believe that nutrition is one of the ways that we can limit these gastrointestinal disturbances, including changes in the gut microbiome. And that's why I put that medical nutrition therapy can come to the rescue in some things. But again, all of these, it's still preliminary. There's not a lot of evidence yet, but hopefully slowly but surely the evidence will come. So the traditional renal diet is one of the culprits. The traditional renal diet was focused on the limitation of a lot of nutrients, particularly micronutrients, including sodium, potassium, and phosphorus. The overall restriction of sodium and phosphorus really led to a lower quantity of fiber that patients could consume, because usually we used to recommend limiting a lot of fruits, vegetables, whole grain, legumes, etc. That is changing now, but the end was, and the result was that a lot of patients were not consuming enough amounts of dietary fiber. We know that protein, it depends on the grade of kidney dysfunction. Usually we tend to recommend a lower protein for those that are pre-dialysis, and then increasing once the patients transition to dialysis. This protein to fiber ratio is not appropriate because there was more protein with less fiber, and that could lead to changes in the metabolites that the microbes are producing, lower amounts of the beneficial metabolites, short-chain fatty acids, and more amounts of the gut-derived uremic toxins that I mentioned, and also probably led to more rates of constipation that are probably compounded, not just the diet, but also the limit fluids and the limit physical activity. Now there is a push for a more liberalized renal diet that is not as restrictive. We're focusing more on the bioaccessibility of nutrients, not an overall restriction, for example, of potassium and phosphorus, but more focusing on the processing of the foods and trying to limit ultra-processed foods because they may contain more additives of phosphorus, more additives of potassium, and more added sodium. So with this, we're hoping that the intake of dietary fiber may improve, that may modulate this fiber to protein to fiber ratio, increasing the production of the beneficial metabolite short-chain fatty acids and reducing the concentration of the gut-derived uremic toxins, and hopefully limiting gastrointestinal side effects, including constipation. So now I'm going to go through some of the interventions that we could use. So one is a whole foods approach. Can we give more fiber and improve gut health? Plant-based diets are probably here the important ones. But plant-based diets are really a very vague term. It is any eating pattern where animal-based food is still consumed, but in moderation, and there are proportionally more choices of plant-based foods. Some of the examples include vegan and vegetarian, the DASH diet that is given for the prevention and the treatment of hypertension, the Mediterranean diet, a more dietary pattern that we're working for people from Mesoamerica, which is Dieta de la Milpa, or diet of the cornfield, the Okinawa diet, the Plato diet, which is the plant-dominant low-protein diet for patients with kidney disease. Some of the proposed benefits, one is really this nutrient, dietary fiber, a higher intake of this, a higher variety of foods that contain different types of dietary fiber, a beneficial fiber to protein ratio, lots of phytonutrients that may also impact gut health, and a lower bioavailability and bioaccessibility of certain nutrients, including phosphorus, but also potassium. So what are the benefits in the gastrointestinal tract? So I highly recommend this review by Dr. Guerrero and colleagues, in which they propose plant-based diets for the benefit of different systems. So in this case, it can improve metabolic acidosis because of the increase in alkali intake, an increased amount of dietary fiber, increasing the production of beneficial metabolites and limiting those that we do not want to produce. And this is exemplified here with fiber. We have more saccharolytic bacteria that can produce short-chain fatty acids, improve epithelial barrier integrity, also giving a more alkaline environment and improvement of insulin sensitivity, reducing inflammation and acid load. Whereas with more intake of animal protein, there may be more fermentation of these amino acids, producing more uremic toxins that can then be triggering more harm for the gastrointestinal tract, in addition to the other side effects mediated by inflammation and oxidation in the cells. The problem with our patients, though, is that even though we want to increase the consumption of this, when we looked into epidemiological data and clinical data, there's a very low consumption of plant-based foods. So dietary fiber, not surprisingly, is lower than the recommendations, and average about 7 grams per 1,000 calories is what patients are consuming, compared to the recommendation of the rule of thumb of 14 grams per 1,000 kilocalories. And also, I mean, I'm not sure in your areas, but there may be some resistance to increase plant-based foods from several health partners. But this is slowly changing because of this big push for the use of plant-based diets. However, it was really interesting in this study is the Diet HD, in which they did 10 European countries and Argentina. They did food frequency questionnaires, and they wanted to see what the patients were consuming and associated with a variety of outcomes. In this case, they're just presenting the median intake of servings of fruits and vegetables per week. You can see that several of these countries are consuming less than 1 per day. So having here 7. So Turkey was consuming a lot less, Poland was consuming a lot less, Italy was the one that was consuming a little bit more. But it's still very, very below the recommendation of fruits and vegetables. In this study by Anthony Mead in Australia, they also wanted to see what was the intake of these plant-based foods. So they showed that about 60% of their population was consuming more than 1 serving of fruit per day, 53% more than 1 serving of cooked vegetables, very limited intake of raw or salad vegetables, full grains, minimally processed cereals. And you can see the amount of legumes consumed in this population, which was really, really low. And also, not just thinking about a plant-based diet is automatically going to be adequate in fiber. In fact, a group, Dr. Capisti's group in Italy, they analyzed different dietary patterns, the normal diet, a low protein diet, a vegan diet, and a very low protein diet. And they showed that at least in the menus that they developed, only the vegan diet was adequate in dietary fiber. Again, thinking about that 14 grams per 1,000 kilocalories, but the normal diet was below. The low protein diet, which we tend to believe that because they're consuming less animal-based foods and we're giving more plant-based foods, they're going to be consuming more fiber. But that diet could also mean more sugar and fat only. So be very purposeful about what you're including in your dietary patterns. And then the very low protein diet, which again, we tend to believe that probably is better because we're increasing or decreasing the consumption of animal-based foods. Again, not adequate in dietary fiber. And also thinking about just plant-based diets, they're not all created equal. Unfortunately, you can have a plant-based diet that is based on fruit juices, refined grains, crisps and chips, sugar-sweetened beverages, and sweets and desserts. And that is definitely not going to be the one that is going to be improving gut health or increasing the amount of dietary fibers. So what can we do when we are starting to do these dietary patterns that we're trying to promote the consumption of these plant-based foods? Do more incremental changes. Do not completely change the dietary pattern. One, because the patient may not be consuming that dietary pattern long-term. We want to do small but achievable changes that will improve outcomes in our population. For these, try to give more variety of food sources, and I will include an example in the next slide of why, just thinking about dietary fiber. If we're using dietary fiber supplements, try to split the doses because some patients may report more GI side effects, particularly if you're using prebiotic fibers, which are going to be fermenting, producing short chain fatty acids. That is a side effect, but patients just need to do it slowly to build tolerance for those. And also, if you're including some low protein diet, low protein and protein-free foods, these are very popular in Europe, particularly in Italy. These have added dietary fiber, including inulin, which is a fermentable dietary fiber. So just be mindful of that. Also, with completely changing dietary patterns, there may be some nutrients of concern. The total amount of phosphorus, we can think about less bioaccessibility in plant-based foods. However, we still need to think about that. With processed plant-based foods, sometimes they do add phosphate additives, sodium and potassium additives, so just be mindful of that. And also when we're using more plant-based foods and limiting a lot of the animal-based foods, just thinking about complementary proteins in order to get all of the essential amino acids in. And this is why plant-based variety is important. We will find different types of dietary fiber with several beneficial effects coming from different sources. So for example, cellulose, it is found mostly in plant cell walls. This is an insoluble fiber. Beta-glucans are going to be, and pectins are going to be most in some specific foods like oats, thinking about beta-glucans and barley. Pectins can be in some fruits. So really we want to get a variety of these in order to get a lot of these different types of fibers. So these are insoluble fibers, and these are water-soluble fibers that can be fermented, although not all of them. And then from the beneficial effects of dietary fiber, thinking the bulking effects to improve constipation, the fermentability, improving the beneficial metabolites and viscosity that can also be either beneficial or detrimental for some absorption of a specific nutrients. These are the different types of fiber. Cellulose is non-fermentable, so it's mostly going to be provide bulking effect. Psyllium, which is a very common, at least in the United States, that is used for the treatment of constipation. This is a viscous non-fermentable fiber. Some other popular fibers, including fructans like inulin, it's going to be providing more of a fermentable benefit because of the production of short-chain fatty acids. And with our patients, what we want is really give that variety in order to go from a minimal dietary fiber intake with more GI side effects. This is a paper for irritable bowel syndrome, but it's very applicable for patients with kidney disease. And we really want to go to a facilitated distal, so have more bulk, have better consistency, have a faster transit time, particularly with constipation, and try to limit the side effects, which is the increase in bloating because of the fermentation of some fibers. So now I'm going to go very quickly so we can get to the questions. What have been studied in patients with kidney disease and those without kidney disease? So psyllium, it is this viscous non-fermentable fiber that may be very good for constipation, but there's been only one clinical study in patients with peritoneal dialysis, I believe. In terms, Dr. Kelly Lambert did a study in which they supplemented or they gave about 27 almonds per day, and they showed that constipation improved after the consumption of this 27 almonds per day. Other potential interventions that have been studied, there was one study in patients with chronic constipation that compared psyllium, prunes, and kiwi, and showed that all of them were beneficial. Some had more side effects, but the kiwi one was that even though it had less of an effect of a complete bowel movement in 1 week, but had the least amount of adverse effects. So that may be another way that we can improve. It's accessible, it is delicious, and it's very high in vitamin C and high in dietary fiber. So just to conclude, there's so many things that we can do, but there's a lot of research that still needs to be done. We don't have a lot of evidence for a lot of these gut health traditional benefits that we think about and that we see in social media, but perhaps through a more plant-based diet, perhaps giving targeted dietary fiber supplements, and maybe with the use of other probiotics and symbiotics, we may be able to improve gut health. But again, there's just still so much to do, and I will be happy to take questions.
Thank you very much, Prof, for that comprehensive and insightful talk. Gut health is where everything is, as you mentioned in your first slide, and it started off, or well, at least I came to know about it while I was doing my my fellowship in nephrology, and one of our nephrology nutritionists was doing a PhD on the gut microbiome, and at that time the gut microbiome was mostly studied in gastroenterology while we were doing our gastroenterology rotation in our physician training. So once that kind of started coming in, I think it just kind of was like a can of worms that just opened up. And I think this is literally we are what we eat kind of thing.
Yeah.
So yeah, so I think interesting, fairly interesting, and we have got quite a few of our nutritionist team on board. That I would expect them to ask a few questions to you. But thanks, Prof, for that insightful presentation.
Thank you. And I see the comment. I really, I'm sorry that I go too fast. I wanted to show a lot of information in a very short period of time, but hopefully with the recording, you'll be able to just look at it at a more slower pace.
Yes, absolutely. The recording will be up in a few days, so you can look at it at your leisure. To the participant who mentioned that. Thank you.
Thank you very much for the nice presentation. I would like to know exactly the amount of calories or savings for an adult patient with constipation. And at the same time, the patient is on dialysis.
The amount of servings of a specific food.
Yes, the specific.
Well, I mean, I will provide, I'm guessing you are perhaps a dietitian?
Yes, I'm a dietitian.
Yeah, so I would provide a little bit more on your management, but thinking about the baseline intake of the patient. Perhaps the patient is consuming a low amount of dietary fiber, a lot amount of fruits, a lot amount of vegetables, a lot amount of legumes, a lot amount of whole grains. So obviously trying to do a slow increase over time of those specific groups and check with their monthly labs to see how that patient is eating. One of the concerns that it's still relevant is about hyperkalemia, but that will depend really on the patient. If a patient is more prone of consuming or having more, it's more prone of developing hyperkalemia, just go slowly and look for the other sources or other causes of hyperkalemia, a specific medication. If a patient is not consuming enough, that is having more muscle wasting, thinking that potassium is mostly within the cell. So if there's breakdown of muscle, for example, there's going to be a higher risk of hyperkalemia. But my recommendation would be try to increase the number and servings of fruits and vegetables, trying to increase the number of legumes, and trying to increase if the patient is consuming refined bread, for example, try to make a small change in increasing more of a whole grain bread, but not at the same time. Do it slowly and also checking with the patient if gut health is better, if it doesn't have any side effects. I am not of the idea of prescribing a specific amount of fruits, vegetables. It really depends on the patient. And that's where the beauty of our job is, to try to individualize that treatment for our patient. And for the fiber, though, try to get to at least 25 grams of fiber per day. Our patients are consuming not enough.
Thank you, Prof. Prof. Bima, your hand is up. Please go ahead.
Thank you very much, for that lovely presentation.
Thank you.
Just to tell you that I always refer all my patients to dietitians because I think they are much more qualified to cover than that I am. So that's good. I want to make a comment first and then I'll ask my question.
Okay.
So comment is that when dietitians come in, and respectfully so, they offer the best possible diet for patients with chronic kidney disease. And I'm talking about patients who before they're on dialysis or transplant. And so I start very early when they reach stage 2 or stage or somewhere, so that we can delay the progression. And mine is mainly from a pediatric point of view because I'm a pediatrician.
Yeah.
So when they prescribe these foods, the problem is cost. The problem is that parents come back and tell me, but the dietitian gave me this list of things but doctor, I really can't afford this. You know what I mean? And so I have to modify it a bit because I understand where the dietitian is coming from and what the parents' concerns are. So I spoke to the dietitians and told them, look, when you are prescribing to a certain group of patients, please understand that cost is a factor, and therefore, you can't ask them to buy this and buy that from Woolies because they can't afford that. You know what I mean? So we have to factor that into our practice rather than prescribe what's in the textbook. But my question to you is that with pediatrics, remember we are balancing two things. We're balancing the kidneys, loss of function against the growth of the child. Now, often I find that dietitians provide a diet when the child is starting to gradually show an increase in the urea levels, etc. That is pretty restrictive. And the problem with that is that, of course, with not enough protein intake, etc., the growth of the child is going to be affected. Now, how do I balance those two things?
Oh, well, that is a very loaded question. I'm going to just start with, I am not a pediatric dietitian, and I do believe that should be a completely different career because kids are so complicated, not little people.
I apologize.
So I think there's still so many things that we in the research space that we could do. Just thinking about the microbiome too. So you may be aware, but some fermentable fibers like inulin can enhance, for example, the absorption of some nutrients that are very important for children, including calcium and including iron. So I don't know if the supplementation of these types of prebiotic fibers may be beneficial for children with kidney disease. I don't think there's been studies on that. The other thing, and I'm going back to probably your comment, is that a healthy diet does not necessarily has to be more expensive. We just need to get more creative, but I just think that it is achievable. We can still use, for example, some staple foods that are canned that some patients are like, no, but the sodium. You can, for example, with beans, you can still rinse them and get as much of that extra sodium and extra phosphorus that they have and still provide a pretty high quality food for the participant and for the patient. Obviously, with fruits and vegetables and all of that, we're not going to be giving those that are out of season, but just try to use those that are in season. Use frozen also if it's feasible. They may tend to be cheaper if you're not using it at the time. Try to limit food waste and still be able to use it. It is harder, but it can be done. And I don't know if I'm answering your question on the growth part. I do believe that there is not a lot of research in renal nutrition in general, but pediatric renal nutrition is even less, unfortunately.
Yeah. I mean, it's something I grapple with myself because I have to balance those things. And I usually tell the patient, and I might be wrong, that look, I prefer the child to grow rather than to save the, save the kidney, because I can always dialyze the patient. But you can't, once they've reached the certain puberty and the epiphysis, they're not going to grow any more than that. You don't, especially in males, you don't want them to be short. So it's a big problem.
It's a really hard balance, because I'm just thinking about bone. You want that maximal bone accrual when they can, not later when they can't, and they just will calcify. But when they can, just try to maximize that. That's a great question, and I'm sorry that I don't have an answer to.
But I really appreciate it. Thank you.
Yeah.
Thank you, Prof. Lima, for your question, as always. Dr. Lloyd?
Yeah. Honorable, I just wanted a small summary of the work that Brandon has done on nutritional supplementation, especially the native foods that are available to people. Just a small summary if you can give. I think that will make a big impact.
I don't think I could understand, sorry.
The use of native nutritional supplements in CKD. I think Brandon has been doing a lot of work. So I don't know if you can tell us something on that. Nutritional supplements.
The use of nutritional supplements, Dr. Lloyd?
Yeah.
Oh, the use of all nutritional supplements?
Yeah.
So that is a good question. I'm not quite prepared, I guess, for that answer, but I mean, at least in the United States, I mean, it's the use of oral nutritional supplements, they tend to give them if a trial of nutritional counseling does not work. I do believe that that may be more monetary reasons because of the access to these oral nutritional supplements. They have been shown to improve the nutritional status, particularly in hemodialysis patients. And also more epidemiological data has suggested that even mortality is improved, also actually less mistreatments, hemodialysis treatments. Sometimes we only think about these commercially available oral nutritional supplements, but now there's a big push for the use of prepare at home, kind of like, what's the name? Natural supplements, but produced with just like regular foods at home that can limit the cost and also improve the nutrition profile and be more individualized to the patient. There is now a lot of evidence that they may be beneficial, and that is because our patients tend to consume lower energy than they should, and this is a way that we can improve energy intake and also protein intake. I don't know if that answers your question.
Thank you so much. Yeah, thank you so much. Yeah. I think there's a lot of work from your side. I mean, Brandon has been doing a lot of work. I think a lot of data collected and things like that again is ongoing. I've not seen the publication as yet, but I think that's a read it, and that's very useful for us. It's extremely expensive to buy these commercial supplements locally here. So we always insist on giving them something, a local food that you can actually augment the nutritional intake. Thank you.
Oh my God, I don't think I could understand.
No, I think he was just appreciating your answer, but also stating that doing the research based on dietetics and nutrition, it's fairly expensive. So we appreciate whatever the information is out there. And we also appreciate that, more information is needed, but it may be a bit more expensive to kind of get it done. So I think that was what Dr. Lloyd was trying to say. What was it, Dr. Lloyd? Sorry, I just paraphrased what we were saying.
There is a lot of work being done from Annabel University on her husband. Dr. Brandon has been doing a lot of work actually. This actually definitely is one of these sometime, and we've done a lot of work on it. Yeah.
Okay. All right. So he's mentioning your colleague Brandon and his work. Yeah.
Yeah.
All right.
I appreciate the shout out.
All right. So we got a couple of questions from our attendees. The first question is, thank you for a nice elaborative presentation. I would like to know more about liberal renal diet versus traditional renal diet, their pros and cons. Thank you.
Yeah, that's a great question. So the traditional renal diet, as you know, was really restrictive towards a general restriction of phosphorus, which really restricted all of the foods with phosphorus, regardless of the bioaccessibility of that. Now there's a push for focusing more on the bioaccessibility of phosphorus, thinking that plant-based foods, a lot of the phosphorus is contained in phytate, and that phytate, the specific enzyme needed for the degradation of phytate, we don't express it in the small intestine. Bacteria can, but that's another story. So therefore, the phosphorus in those plant-based foods is going to be lower. Moderate concentration of phosphorus coming from animal-based foods, and then a higher bioaccessibility, meaning that phosphorus is available for absorption coming from processed foods that contain phosphate-containing additives. So the newer, more liberalized diet is focusing on that, trying to focus or limit the amount of phosphate additives consumed from ultra-processed foods. In terms of potassium, there's now another push too. We tended to restrict a lot of the plant-based foods because of the concentrations of potassium in those foods. But now there's some evidence that suggests that a plant-based diet may be beneficial because of several reasons. One, the bioaccessibility of phosphorus coming from plant-based foods may be also different in those plant-based foods compared to ultra-processed foods with potassium-containing additives. Two, with the consumption of plant-based foods, you have a higher consumption of fiber that may help with constipation. And one of the ways that we can excrete potassium is through fecal output. So if we have constipation, we have a higher risk of developing hyperkalemia. So with a higher plant-based foods, higher fiber intake, we may be able to limit our risk of hyperkalemia. When terms with sodium, that has not really changed. Now the changes with fluid, it's slowly changing. It's more focusing on limiting sodium because that may enhance thirst, and just focusing on drink when thirsty instead of just having an overall fluid restriction. So that's really the newer push for the liberalized diet. Now it's more based on a lot of views. There's not a lot of primary research yet, but also thinking about the quality of life of the patient. If a patient is under a very restricted diet, they're likely not to follow that restrictive diet. It may go to the completely other side and be unrestricted, consuming more ultra-processed foods, more sodium, potassium, and phosphorus. So that's why it's kind of like a balanced effort between what you're giving and what your patient can achieve.
Thank you so much for that answer. The next question is, among GI symptoms that are highly prevalent in chronic kidney disease, you mentioned indigestion, which is accounted for about 70% in patients on hemodialysis. Mm-hmm. Can you elaborate a bit on nutritional management of indigestion in these patients? So
a lot of it can be with dyspepsia, and if they have, for example, gastroparesis, and that is probably once it's coming, like what the data is coming from. So using whatever recommendations that you have for gastroparesis. Now, one of the things, I'm moving ahead with a lot of these newer drugs for the obesity management. They can also slow gastric emptying. And therefore, we probably, if a patient is starting to use this, I'm just using it as an example, try to give more smaller meals, but more constant in order to get those calories in. And that's probably one of the best recommendations that we can give for that.
All right. What about using medication that would improve gut motility? I know it's the additional pill burden and probably polypharmacy, but maybe that would be something that would also help.
Yeah, some prokinetics could be given that could improve. However, what I know is that there may be just a short-term benefit, and we may not be able to use it for the longer term. So just hoping that the GI side effects will be lower. But I guess in terms of food intake, what we could just give is try to not give big meals, because a lot of our patients, at least here in the US, consume 2 very big meals, and instead try to give perhaps 3 or maybe even 4 to try to limit that dyspepsia and indigestion that the patients are having.
Thank you so much. Another question is that a patient was having diarrhea for almost 2 weeks and had gradually improvement, although it's ongoing treatment. What possible actions and type of food might be advised for the diarrhea?
So with that obviously it will depend if it's an acute gastroenteritis or if it's a chronic diarrhea. Psyllium actually, so the supplement has been used for the treatment of constipation, but because it's also a viscous fiber, it may also be able to absorb endogenous or intraluminal water. In kidney disease, it hasn't been studied. So I will probably just be more cautious if it's just like an acute gastroenteritis versus a chronic gastroenteritis. Psyllium, again, it's one of the foods. Try to limit some irritants and things like that. It's more of a general recommendation. I always feel like wrong giving just specific recommendations, because obviously it will depend on each type of person and patient. And I am really sorry I have to go to another meeting.
No problem. Please, thank you very much. The questions, unfortunately, are coming in now, but it's okay. We can always have another session with you sometime whenever you're free, and we will take these questions at that time. But again, I would like to thank you very much for your presentation and for your availability. And hopefully in the future we'll have another talk with you. So thank you very much for that, Dr. Lloyd.
For sure.
Thank you very much. Thank you, Annabel. Thank you very much. I know there's one more talk coming up next month, so I'm sure you can ask all these questions next month. Yeah.
Yes.
Thank you so much.
Yes. Thank you so much.
Thank you. Thank you very much. Have a nice day. Thanks.
You
Bye.
too.
Bye.
Bye.
Bye.